Hi everyone, I'm Dr. Preeti Sharma and I'll be discussing the pathology questions that came in the exam on Jan 20th for the FMGE students. Well, the overall reaction to the paper was definitely a set of mixed reactions because paper 1 definitely went a lot better for the students in comparison to paper 2. And after having analyzed both the papers, yes, definitely the questions in the second paper, especially to do with surgery and medicine, were on the higher side. They were extra edge. They were not what we were expecting in the FMG exam. Some of them were not even up till for the NEET PG exam, to be honest. But yes, all said and done, let's keep our spirits high and let's stay positive that at the end of it, we have to cross a 150, keeping both the papers in mind. So on that note, guys, let's begin. Now, this session is not just for students who gave the exam, because I think by now all of you do know and are aware of most of the answers. This session is also most importantly for the students going forward. The students who are targeting March 5th, that is NEET PG, and the students who are targeting June FMG, this session thereby stands of importance for you guys. Having said that, let's begin with the very first question over here. There's a 50-year-old female who came to the hospital with headache. Firstly, so there's a female with headache, something to do with, and if I go ahead and read further, there has been a frontal dural based tumor that radiology has told me, and there's a tumor measuring 3/2. So firstly, if they've mentioned a lesion, because if I look at all the options, one of them was to do with meningitis. See, a meningitis is not going to come to you with a lesion. Also, one more thing that is mentioned is that the patient is afebrile. Again, meningitis patient is going to come to you with fever, right? So that aspect is totally ruled out. They have told me a lesion measuring 3/2. So somewhere there's a tumor, and there's a tumor which has come to you with headache. Which of the following will you most likely observe in the same? So guys, now looking at all of these, if I had to pick up one, considering that it is a dura-based tumor, obviously I will think of meningioma. We would be thinking of meningioma because that's the only one over here which comes up from the dura. So first let me show you, and they did not give this to you as an image-based, is what most students said. They gave more or less as descriptive. So what does meningioma show you? Image number 1 for the students going forward. Meningioma is a tumor which you need to keep in mind has classical features. Everything goes round and round. When I say round and round, means the cells are also going to go round and round. There's a whirling of the cells, and the calcium is also going to go round and round. And we all know that when the calcium goes round and round, that is a condition known as the Samoma bodies. So simple. Meningioma, everything going round and round. Tumor cells also, calcium also. So when we zoom into this picture, I think we can all visualize that. Look at these tumor cells. They are also arranged in a round and round fashion. Yes, all of you can visualize that. And can you see the calcium part? That is also Samoma bodies going round and round. So coming all the way back, that is what I wanted to see, because this is dura based. If you guys remember, just prior to the exam we had discussed and I had told you CNS tumors and meningioma is their all-time favorite. Look at the other options, which is the tumor that shows you fried egg appearance. That tumor is an oligodendroglioma. And I think this is a very famous question because the way you write oligodendroglioma tells you everything. We'll write it once again. But this time I will write it as oligodendroglioma, because this has the maximum O's in it, the maximum eggs, andas in it. This means this is the tumor which is going to show you the fried egg appearance. Have a look at this picture. Can you see there's a blue color nucleus, and then there's an area of white area around it. Again, every nucleus you will eventually see has a whitish area around it. Perinuclear, we can see all those white areas. That's a fried egg appearance. Not only fried egg, if I look very carefully, I used to tell you one rule. Rule of the universe, wherever there is an egg, there will be a chicken. So what other than fried egg appearance does it show you? It also shows you the very famous chicken wire blood vessels. So if you look very carefully, there are some lines going in between. These lines are the chicken wire is very thin fencing that they do to keep the chicken in control. So yeah, that is going to be chicken wire. So the rule is that whenever there is an egg involved, there will always be a chicken also involved in the story. That is oligodendroglioma, but I couldn't have selected oligo here because it was a dural based tumor. The third one mentioned was Antony A and Antony B areas, and where do you see it? You see it in a case of schwannoma. So going forward, when I look at all these pictures, this is the classical picture of a schwannoma which we must quickly revise. As they said, schwannoma shows you some areas called Antony A, and it shows you some other areas known as Antony B. So how will I learn which is A and which is B? So A area is the one which is said to have a lot of cells, hypercellular, like I learned. Anthony A is going to have a lot of cells. Can you see this much area? It's so pink, it's got so many cells in it, yes? Versus Anthony B, I have learned B is blank. B is blank, which means it is the hypocellular area. So please remember, Anthony A has a lot of cells, hyper. Anthony B is blank, that is hypo. So I always say that this schwannoma picture looks like a photoshopped image, as if two very different pieces have been stitched together. It looks pretty much like a Photoshop. Having said that, what else? Are there very famous bodies? And you can see those bodies. They are seen in schwannoma. They are very famous questions, Verroque bodies. So guys, first we'll draw a Verroque body. How does it look like? There are 2 rows of nuclei. There are 2 rows, and can you see how I've drawn the nuclei? Parallel to each other, palisading. There are 2 rows of palisading nuclei that you need to know. And if there are so many nuclei, where did the cytoplasm go? All the cytoplasm is going to be in the center. So here you have the cytoplasm that is present in the center. This entire thing is a Verroque body. So have a look at it over here. You can see 1 row of the nuclei here, 1 row of the nuclei here, and all the cytoplasm is here in the center. So this entire thing now becomes a Verroque body. Having said that, coming back, this was the most important question even for students going forward. One more thing, there was a history of a female given, although we never just make a diagnosis of male based on male female, but meningioma, let me tell you, meningioma is the brain tumor which is more common in females, so much so that it is said to be dependent on a hormone. Progesterone receptor positivity is seen in meningioma. So the female history over here is also quite characteristic. All said and done, based on Dura, I got my answer. Dura mentioned I have to think of meningioma, everything going round and round, right? Let's move on to a simple one-liner which they asked you. Nitric oxide is formed from which of the following amino acid? I didn't know whether to place this in path or biochem, but I just got it here, which is very, very obvious. Everyone remembers that famous reaction. L-arginine is going to, in the presence of nitric oxide synthase, give nitric oxide and L-citrulline. L-arginine gives nitric oxide and L-citrulline. So yes, nitric oxide is going to come from arginine. Clear-cut answer. Now remember, with regard to arginine in pathology, there are just 2 questions that are important. Okay, so actually 3. If I include hemat also, there are 3. Number 1, it's going to give rise to nitric oxide. That's the question here. Number 2, it is associated with a type of killing. If you go back to your first chapter and you study NETs, in NETs they ask you what is the amino acid needed, and that is arginine. Number 3, there are some arginine-rich mitotic spindles. I'll draw one. This is a red blood cell. And if I draw something like a figure of 8 appearance, which ring does it remind you of? It reminds you of Cabo ring, doesn't it? So now next, go and study what is the composition. What is a Cabo ring made up of? You will study it is made up of arginine-rich mitotic spindles. So yes, that is going to be all about arginine that you have in path and hemat. I hope that will help you. So remember, arginine makes nitric oxide, is associated with NETs, is present in a Cabo ring. And which anemia shows you Cabo ring? A quick completion, vitamin B12 deficiency, that is megaloblastic anemia. Let's move on to another one-liner, quite classical. Serum or plasma contains a maximum of. So basically they asked you the blood levels of which antibody is maximum. I think everyone remembers the favorite GAMD mnemonic. GAMD tells you that we are going from maximum concentration all the way up till the least concentration present in the blood. So yes, the clear-cut answer to this question was IgG. IgG has the maximum. Now a quick one word if I can make you revise. Guys, please remember, when you're talking about IgG, this is the one that can cross the placenta. That's their all-time favorite question. I hope you also remember this is the one which is a very famous opsonin. The most important opsonin is IgG. When they talk about A, there are 2 questions. This is the antibody present in our mucosa. So you call it mucosal antibody, respiratory, GIT, these mucosas have it. This is also present in the body secretions. So we also tend to call it the secretory antibody. And let me tell you, just in case they would have given you that which is the concentration maximally present in some body secretion like breast milk, you would have marked IgA. Talking about M is the millionaire antibody. It is the Ambani of this family because it has the maximum molecular weight. It can bind to maximum antigens. It can bind to maximum antigens. Okay, coming on to next. What is D? The most docile one, because it is just a B cell receptor, nothing fancy about it. E is the one that is involved in which hypersensitivity? Hypersensitivity 1. So that means it is associated with all the allergic reactions and all the parasitic infections. That's a very quick recap, a 1-2 minute recap of this GAMD. Always remember GAMD because G is maximum in the blood. So this is sorted. Another one-liner coming up your way. This did not come as a one-liner, but we could not gather the entire history from the students, but all said and done, it was quite simple because feco-oral is which hepatitis? So I hope you remember hepatitis A and E are going to be feco-oral, of which E I don't see over here. So I had to pick up classical hepatitis A. That was the answer. So that is the feco-oral one, hepatitis A. So quick questions done. Let's pick up a next one. I didn't know whether to place this in gynae or in path, so I've got it here. There's a patient who's complained of a frothy greenish discharge per vaginum, and which of the following is the causative agent? So please remember, over here you need to be very cautious because you have got one of the most important buzzwords over here. When you get these buzzwords, life becomes a lot easy, so you don't have to overthink over here. This is Trichomonas vaginalis. Quickly I'll tell you what all about Trichomonas should you be knowing, be it path or be it micro. So when you talk about Trichomonas vaginalis, please remember this is the clinical picture. The clinical picture shows you that what has happened to the cervix. The cervix has these red color spots. So what do you want to call it? This is referred to as the strawberry cervix. This is referred to as the strawberry cervix. Now I have learned that if you look at a strawberry, the lower part of it is all red, but the top part of it is going to be all green, because that green will remind me that Trichomonas vaginalis patient is going to come with a greenish discharge. So yes, having said that, the strawberry reminds me of the cervix and the green color on top reminds me of the discharge. Now going forward, how will it look under the microscope? So remember, Trichomonas, for everything else, we always study that there is a trophozoite and there is a cyst. For all the parasites, right? Be it entamoeba, be it Giardia lamblia, any other, we say there's a trophozoite, there's a cyst. But T for T. When we talk about Trichomonas, the only form is the trophozoite. Please remember, trophozoite only means there is no cyst form. And another T that you need to know, what is the motility that it shows you? It shows you the twitching motility. So please remember, there is going to be a T and T and T. Trichomonas, trophozoite only, twitching motility. How is the trophozoite going to look like? Let's quickly draw it. It's going to look like this with one nucleus, means one nucleus is there. There are going to be 4 hair coming in front and there's going to be one hair-like structure coming from the back. So what are these hair-like structures? These are flagella. I can say that it is going to have 4 anterior flagella and it is going to have 1 posterior flagella going all the way back with an undulating membrane that you must have read in micro, right? So having said that, they've always said that this trichomonas occurs in ladies obviously, because it can occur in men of course, but there's a very famous mnemonic that we study in microbiology. There are 2 organisms very similar looking. There is a Giardia lamblia and there is a Trichomonas. So they always say that Giardia lamblia is the old angry uncle and Trichomonas is the auntie. So auntie basically means this is quite a fancy auntie, because I was teaching some of the plus students and they came up with an impromptu story that Trichomonas is a very fancy auntie. First and foremost, she is eating strawberries, so she's eating all exotic fruits. After that, look at her haircut. They said that she has a fringe cut. She has a fringe cut, so 4 hair anteriorly and then 1 long hair going posteriorly. So that is how they learned. And yes, this is exactly what you see when you're talking about the different trichomonas, right? I hope that is okay with everyone. Coming back, this was the greenish discharge. I selected trichomonas, but what would have been the discharge if they would have wanted to give me candida? So remember, candida shows you a curdy white discharge. Candida shows you a curdy white discharge. And this candida is then going to now come over here and on a pap smear show you a very famous food item which is ruined forever in your life, and that is a shish kebab effect. Now, what is this shish kebab effect? So obviously you've eaten shish kebab. I don't know whether you will be able to eat it going forward, but candida on a pap smear looks shish kebab. Means what is that? That stick on which all the kebabs are put, you call it a skew. So that stick is basically the pseudohyphae. That stick is nothing but the candida pseudohyphae. And what are the pieces of kebab that I'm going to put on top of it? These are the cervical cells. This is the cervical epithelial cells. So can you see all the cervical epithelial cells have come in a line like this, like pieces of a kebab are arranged. That is the shish kebab effect that you see in a case of candida showing you a curdy white discharge. Here there was no curdy white, it was a greenish, so you thought of obviously Trichomonas vaginalis. Having said that, moving on to the two very famous owl eyes which came, and there was some students who were telling me that how they showed you the two owls in paper 1 and made you an owl in paper 2, because paper 2 was obviously tougher. So yeah, so what is the owl that you have over here? They've got you a lot of infections mentioned, and if infections are there, there's no doubt about it that the owl eye is seen in cytomegalovirus. So this was the first owl eye that was mentioned. There was another owl eye that they had shown you, that is a biopsy was taken from a 30-year-old male and following was seen. So again another owl eye was seen, and this time the answer had all lymphomas. So which is this owl eye? This owl eye is the very, very famous Reed-Sternberg cell. This is the Reed-Sternberg cell which you see in a case of Hodgkin's lymphoma. How do we differentiate between these two owl eyes? So let me tell you. So see, in both of them we'll draw the same cell. There's one big face over here, one big face over here. We are going to draw the two eyes in it. Now the color of the eyes is important. If I end up drawing pink color eyes versus if I end up drawing blue color eyes, that is what you have to see in the exam. If I end up drawing pink color eyes, these are Reed-Sternberg cells which you see in Hodgkin's lymphoma. If I draw blue color eyes, this is the cytomegalovirus. How do I learn it? So firstly, remember, Reed and Sternberg were two female scientists. Reed and Sternberg were two female scientists. So basically they have pink inclusions or pink eyes. Girls ka favorite color, females favorite color, pink. Whereas when we are talking about cytomegalovirus, mega, men are usually bigger in structure, in overall build. So mega for men, and remember for men the favorite color is blue. So for girls it's pink and for men it's blue. Over here if you saw, there was actually no source of confusion because when they showed you this, they only gave you infections. So you could easily pick out that CMV is the infection here, and here they gave you all lymphomas. So here you had to pick up, okay, this is a Reed-Sternberg cell and that obviously is a Hodgkin's lymphoma. Going forward guys, they will ask you markers of a Reed-Sternberg cell. What are the markers? CD15, CD30 and PAX5, and which of these is the sensitive marker? CD30 is said to be the most sensitive and PAX5 is said to be the most specific. I hope that's sorted. Let's move on to the next question, which is this. So yes, there were 2-3 questions which were there from the kidney chapter also. There's a 5-year-old boy who's presented with periorbital and pedal edema. Periorbital and pedal edema. As soon as edema comes and there is ascites, and they have said that there is obviously a kidney because they have said there is electron microscopy showing you effacement of podocytes. Podocytes by default means kidney. So look at the catch points over here. What is the age group given? Number 1, it's a child. Number 2, when edema is mentioned, means which syndrome are we currently in? We are in nephrotic syndrome. Yes, and once they say child, so let me first pick up. So SLE is not going to happen in a child. It's not neonatal at most of the places. IgA tends to occur in adults. FSGS, and more than that, IgA is nephritic, right? FSGS also occurs in adults. If I just had to pick up on the basis of the age also, I would have picked up minimal change disease. But let me tell you, in minimal change disease, what is the gold standard? What is the gold standard for the diagnosis of minimal change disease? Exactly what they've mentioned. Effacement of the podocytes. Let me show you a picture over here. Have a look at this. See guys, divide this photo into two parts. You can very well visualize. These are electron microscopy, black and white kind of pictures. And you see that in this picture I see nice feet drawn. Feet or what? These feet would basically be foot processes or the podocytes. They will be foot processes or the podocytes, and suddenly in the next picture I realize those foot processes or podocytes are effaced, and that is exactly what you see as the gold standard. That is what I am saying, that those podocytes will basically be effaced, and that is the gold standard for minimal change disease. And let me tell you, why did I pick it up on the basis of age? Because this is the most common nephrotic in children. This is the most common nephrotic that you see in a child. And the next important point is, that is not written here but should have been, they show you selective proteinuria. Selective proteinuria means, what is proteinuria? Protein going out into the urine. Protein going out into the urine. So protein is going out, but selectively which protein is going out? Selectively albumin is going out. There is a particular albumin loss. Does that make any clinical significance? When there is selective proteinuria, only albumin is going out? Yes, clinically when you will treat this patient with steroids, this patient is going to show you an excellent response. There's an excellent response that you will get when you treat this patient with steroids. So remember, that is the concept of selective proteinuria. I hope this question everyone got it right in the paper. Let's move forward, because you had another kid in the exam and another urine related finding, but this time the kid had hematuria and presence of red blood cell cast. So first and foremost, when this aspect of blood has come up, now the syndrome that you will be talking about in the kidney is going to be the nephritic syndrome, right? Okay, now tell me, nephritic syndrome and occurring in what? Pediatric. But now there's a little bit of discrepancy in the recall over here, because some of the students were saying it wasn't pediatric, it was 20-year-old. That is one thing which a lot of students told me. But even if you put it in that, even if you put it across that, at least you know it was nephritic. So first, minimal change disease is nephrotic. FSGS is also nephrotic. When you talk about membranous glomerulonephropathy, that is also nephrotic. So then in that case, even by going by this concept, you had to select post-streptococcal glomerulonephritis. Also, a lot of students did recall that there was a history of a throat infection that was given in some cases. Some students had told me. So throat infection further tells me about streptococcus. Throat infection tells me about streptococcus, which basically means we are dealing with post-streptococcal glomerulonephritis. And post-streptococcal glomerulonephritis is the most common nephritic, P for P, PSGN in pediatrics. PSGN in pediatrics, most common nephritic in the children. Even if it was a child or not a child, but if throat infection was given, hematuria was given, nephritic syndrome was there, this is the only option that you could have selected. But quickly tell me, if going forward you get some questions on PSGN, what is the classical kidney appearance? And this was a NEET PG PYQ, the exact same picture was put up. What do you see? This is the classical flea-bitten kidney. This was the classical flea-bitten kidney. So this is what you see. Do you only see this in PSGN? Can you all recall the very famous mnemonic for flea-bitten kidney? And that is we hate PSM. So this was supposed to be our secret. I always used to tell you, please don't tell the PSM educator that you know we have made such a mnemonic. But I remember I was taking a class with Dr. Neha a few days ago, and one of the students came there and told that we have a mnemonic called we hate PSM. Then I had to give a lot of clarification. All said and done. Yes, flea-bitten kidney. Where all do we see it? We see it in Wegener's granulomatosis. Number 1, Wegener's granulomatosis. H is for HSP and HUS-TTP. HSP, I hope you all remember, Hinox-Schönlein purpura. HUS-TTP for hemolytic uremic syndrome. Okay, P for what is in front of you, PSGN, can also be seen in polyarthritis nodosa. S for subacute bacterial endocarditis and for SLE. And M for malignant hypertension. So what are all the conditions? Repeating. So V for vaginous granulomatosis, H for HSP and HUS, P for PSG and PAN, S for SABI and SLE, and M for malignant hypertension. Right now I'm reading this because we are dealing with the case of PSGN. So if this is a flea-bitten kidney, what exactly is a flea-bitten kidney? Flea. If an insect bites you, flea-bitten. If an insect bites you, that area becomes very red. So I realized that this area was becoming very, very red. What are these red things? These are pinpoint hemorrhages. These are pinpoint hemorrhages. Having said that, if I look at this under the microscope, if I look at a case of PSGN under the microscope, this is the immunofluorescence which shows me the very famous starry sky appearance. How do we know starry sky appearance? Shining and dull, shine like stars are twinkling. So some areas you will feel are shining a lot. Some areas are going to be shining a lot. Some areas you will feel have fallen a little dull like the sky. So twinkling. Twinkling is how you see. Somewhere green color is more, somewhere green color is less. That is starry sky appearance. Next, look at this black and white photo, electron microscopy. Always pick up the podocytes first. These are the podocytes. I can see, let's trace them all throughout. Suddenly one podocyte has become like a mountain. That tiny little foot has become like a mountain. Why? Someone is sitting besides it, below it. Subepithelial humps. It shows you the presence of subepithelial humps are noted. So remember, for PSGN, image number 1, we see the flea-bitten kidney. Immunofluorescence shows you starry sky appearance, and electron microscopy shows you subepithelial humps. Although all of this was not there in the question, but just for your revision. Having said that, moving on to the next one. Quite unexpected, quite a classical. 70-year-old male, as soon as we see an elderly person coming to you with hip pain or any bony pain and lytic lesions over there, we have already started thinking of multiple myeloma. So for the NEET PG students, if some elderly person is coming to you with lytic lesions in the bone, think of this tumor multiple myeloma. And the same way, if a child would have come with lytic lesions in the bone, always keep in mind a disease which you often forget, and that is Langerhans cell histiocytosis. Both of these are previous year NEET questions. So repeating once again, elderly with lytic bone lesions, multiple myeloma like in this case, but a child with lytic bone lesions, LCH. Okay, right now what else do I see? Serum calcium levels were raised because I know that there's a very classical mnemonic that we have for multiple myeloma, and that is the crab mnemonic. So what is the crab mnemonic? Firstly, what is there? Bony lytic lesions. Bony lytic lesions. If the lesions are breaking, if the bone is breaking, where is the calcium going? All the bone will break, the calcium will go into the blood. Hypercalcemia. The renal insufficiency is going to be there. Renal insufficiency is going to be there, and patient also has anemia. So the CRAB criteria: calcium, renal, anemia, bony lytic lesions. These are the 4 things that are needed, and calcium levels are raised over here, bony lytic lesions are present over here. What else? Finally, they have given you plasma cells are more than 42%, or somewhere around that number was given in the bone marrow, which further tells me it's a case of multiple myeloma, and this exact same picture was also given to you. So first and foremost, you should be able to identify that this is what? This is a plasma cell. So that's the first identification that you should be able to do. So how do you identify, and this is especially for the NEET PG students, how do you identify between a plasma cell and how do you differentiate a plasma cell from a very close mimicker known as an osteoblast? How do you differentiate between them? So let's draw it out. For example, these are the 2 cells. In both the cells, the similarity is that I have drawn the nucleus over here. I have drawn the nucleus eccentric. That is why they are looking so similar. Both of them are looking so similar because in both of them, the nucleus is going to be eccentric. However, then you have to notice on the white area around it. If you look at a hollow area in plasma cell, you have a hollow area around the nucleus. There is a perinuclear halo, whereas in an osteoblast, the halo will be somewhere away. That is going to be a paranuclear halo, somewhere away from it. There is going to be some away halo present. If you ask me why is there a white area, the composition is the same. This is also made up of Golgi apparatus. This is also made up of Golgi apparatus. The only difference is where that halo is present. If it is present just around perinuclear, I call it a plasma cell. If it's far away, then I call it an osteoblast. So have a look at this picture. See. Compare both in front of you. Can you see this cell also has a nucleus on the periphery, this cell also has a nucleus on the periphery. So now if you see the white area, zoom into each. If you see the white area here is just around the nucleus. So this perinuclear, this must be a plasma cell. Whereas over here, if you see very carefully, the whitish area is a little far away. Far away means this is paranuclear, means this is an osteoblast. So first thing, when you look at this question, this is definitely a plasma cell. Now let's move on further that yes, this is a case of multiple myeloma, but what other pictures could have been given to me over here? So all of us have heard of the famous Russell bodies and the Dutcher bodies, and that is exactly what we are going to look at next. Please remember that over here, if you see the first image that is shown is a Russell body. The next image shown is a Dutcher body. And how will I differentiate between both of them? Please remember, if the inclusions are seen in the cytoplasm, that is intracytoplasmic, that is Russell bodies, and if the inclusions are seen in the nucleus, that is intranuclear, that is a Dutcher body. Let's zoom in and have a look at these pictures. See this, guys. Can you see the whatever things we are seeing are in the cytoplasm? These are all in the cytoplasm. So cyto has that C sound, na? Cyto has that C wala sound. So Russell bodies are seen in the cytoplasm. Whereas look at these, where are the bodies present now? They are present in the nucleus. They're present in the nucleus means they are intranuclear, they are Dutcher bodies, right? Whereas when they start looking like an entire bunch of grapes or a berry, that is known as the famous mulberry or the Mott cell. That is known as mulberry or the Mott cells. And finally, you have a cell which is on fire, and that fire cell is going to be a flame cell. So these are the four very famous cells that you have in multiple myeloma: Russell, Dutcher, Mott or mulberry, and flame cells. But if you ask me the composition of all of these, they are all primarily made up of the same thing, and that is immunoglobulins. So the composition of any of these bodies is asked and you say immunoglobulins. The same thing. Now you know what are these pictures? These are all bone marrow aspirates, because now what I'm going to show you is the very, very famous bone marrow biopsy. Biopsy means I've got you the pink and blue, and this is a picture that comes in so many of your GTs, and everyone sends me screenshots saying that how do you identify it? Identification is the same. If I pick up this cell, where is the nucleus going to be? The nucleus is on the side, that is, it is an eccentric nucleus, and there's a white area around it. Same way, pick up this cell. Where is the nucleus? The nucleus is on the side, and there is a white area around it. So the picking up of the cell morphology is going to remain the same, whether it's an aspiration or whether it's a biopsy. So actually speaking, this is going to be having sheets and sheets of plasma cells. What exactly are those? They are sheets of plasma cells. But how do you identify a multiple myeloma? I think the last thing that I can tell you for multiple myeloma is the very famous M spike. And now guys, the first thing, when I say M spike, I mean myeloma monoclonal spike. I do not mean IgM. M is for myeloma monoclonal. So there is an M spike that you see, but that's not IgM, because which is the most common antibody that is increased in multiple myeloma? It is IgG antibody which is increased. So have a look at this. See the, firstly, what is SPEP? If they ever write it, you have done a serum protein electrophoresis. You have done a serum protein electrophoresis. So basically, you are wanting to know the proteins in the blood, and you see normal person's antibodies are looking like this, but in multiple myeloma there's a spike that has gone up because you have lots of IgGs in it. So this was everything to do with multiple myeloma, although they asked you a very simple question which anyone could have answered very easily, but we've done a quick recap. Let's move on to the next question. Which of the following is made up of TAM horsefall protein? I personally felt, it's just a personal opinion, that this question was not correctly framed, or we have not got the correct recall, because please let me know if this was the scene or not. caste, be it any caste, is made up of TAM horsefall protein. Do you know what? I'll first show you. See, which caste is, answer over here is Hyline caste. That is fine. If I had to pick up an answer, I'll pick up a Hyline caste. But why I feel that this question was not framed well is because every caste, be it Hyline caste, RBC caste, WBC caste, every caste is made up of TAM horsefall protein. What is sticking on top of that caste is going to change it. So if it comes out only as TAM horsefall protein, I call it Hyline caste. Only the protein is coming out. On top of this, if for example red blood cells will stick, I'll call it red blood cell caste. If white blood cells will stick, I'll call it white blood cell caste. If dead cells will sit on it, I'll call it muddy brown caste. So ultimately the base is the same in every caste. So this was not right to ask that which caste is made up of TAM horsefall protein, unless they asked you which caste is having only TAM horsefall protein and nothing else. That is a Hyline caste. So first and foremost, which part of the kidney makes TAM horsefall protein? It is made by the loop of Henle. It is made by the loop of Henle, question 1. And which caste is it primarily going to make? Hyline caste. Hyline caste in most of the cases is seen in normal physiological situations. A normal person can show 1 or 2 Hyline castes in the urine, not a problem. Pregnant females can show 1 or 2 Hyline castes, not an issue. But in severe dehydration and fever, also you can see the presence of Hyline castes. So coming back, when I had to select one, I would have selected this. But again, like I said, not the best framing of the question. Okay, having said this, let's move on to the next one. We are back to another question from kidney. Patient presented with hemoptysis and hematuria. As soon as these two organs are mentioned, I think I know my answer. Hematuria means involvement of kidney, hemoptysis means involvement of the lungs, and there is one organ that shows you both involvements, and that is Goodpasture syndrome. As of now, I feel my answer is Goodpasture syndrome, but I need some confirmation. Goodpasture syndrome is antibodies against what? Antibodies against the glomerular basement membrane. If you guys remember, Goodpasture has always been our 1, 2, 3, 4 syndrome. What is 1, 2, 3, 4? It belongs to which family of RPGN? It belongs to first type 1 RPGN. Okay, which kind of hypersensitivity reaction is it? Type 2 hypersensitivity. What is the collagen affected? Any basement membrane, basement always has 4 collagen. There's a mnemonic also by which you learn it. Whenever you talk about basement, basement basically responds to the floor, and floor will remind you of 4. So remember, the floor or 4 is what is important. So type 4 collagen is there. And which chain of type 4 collagen is affected? Alpha 3 chain of type 4 collagen. So repeating, it is type 1 RPGN, type 2 hypersensitivity, alpha 3 chain of type 4 collagen is affected. That is Goodpasture syndrome. And basement membrane is present in basement membrane is present everywhere in the body, but 2 main organs affected are, one are the lungs, that is why patient had hemoptysis, one is the kidney, that is why the patient had hematuria. Okay, I hope that question is sorted. We can move on to the next question, which was quite an easy one. There's a 44-year-old female with wheezing, cough every year at a time period of the season change. Some allergic reaction this is sounding like. Degranulation of which of the following cell is responsible for it? So first and foremost, which hypersensitivity is this reminding you of? It's reminding us of type 1 hypersensitivity, hai na? And now in type 1 hypersensitivity, I have to watch out for what exactly has been asked. There are 2 cells which are going to play a very, very important role. If they would have asked me that in the late phase of hypersensitivity type 1, which is the cell that has increased, it is eosinophils. But in the early stage, plus which is the cell that is going to degranulate and burst, that is going to be a mast cell, because when this mast cell degranulates, what is the most famous mediator that is going to be released? Mast cell is the richest source of histamine, and histamine is responsible for all these symptoms of wheezing, cough, pruritus and all of that. So histamine comes out because the mast cells have degranulated, and that is your answer over here. There's a previous year question that has come in the NEET PG exam. Mast cells, is there any special stain? I'm sure all of you are aware mast cells are stained by toluidine blue. Having said that, let's move on to the next question. A lot of students wrote to me about this question. Splenectomy is indicated in which of the following conditions? So first and foremost, the answer to this question is hereditary spherocytosis, because see, what is hereditary spherocytosis? What is the most common? genetic problem, that is encheirin mutation. It is an encheirin mutation. Now guys, tell me something. Can I treat a mutation? No, mutation is permanent. I can't do anything about it. But I know that because of this mutation, my red blood cells are becoming spherical. Spherocytosis. I have spherical cells or spherocytes which are forming, and I know that these are being destroyed by an organ. These are being destroyed by the spleen. So basically, what kind of hemolysis is happening? Is the hemolysis happening inside the blood vessels? No, the hemolysis is happening outside the blood vessels. The hemolysis is happening in the spleen. This is an extravascular, outside the blood vessel, extravascular hemolysis. So now I put a little bit of common sense that I can't do anything about this mutation. This will stay for a lifetime. But the main destruction of my cells is happening in the spleen. So let's remove the spleen. Let's do a splenectomy. So what is the treatment that you give for hereditary spherocytosis? You do a splenectomy, because if your spleen is removed, there will be no. So now I'll say, if the spleen has been removed, there will be no hemolysis, no one to break the blood. The spherocytes will still be there. See, the genetic mutation is still there, so those round cells will form, but no one is there to kill those cells. So the spleen has been removed. A lot of you wrote to me that no, we thought ITP was the answer. I have been explaining this to a lot of students since that day, that ITP is of two types. Immune thrombocytopenic purpura is of two types, acute ITP and chronic ITP. For acute ITP, we've always said it is a self-limiting disorder. You actually don't have to do much about it. Within 6 months, things get back to normal. You just have to do supportive treatment of the patient. For chronic ITP, we first always go in for steroid treatment. We're never going to jump on to doing a splenectomy first. If it is a steroid resistant case, then you can still consider splenectomy, but not going to be one of the first lines of treatment. So yes, having said that, answer to this, undoubtedly HS. Coming on to the next question. Newborn born with a reddish lesion, a newborn with a reddish lesion on the upper eyelid. Many students said this was the exact picture given. Possibility of a vascular etiology looking at the red color is kept. Answer to this question is a capillary hemangioma. First and foremost, guys, in the exam, whenever you are confused between a capillary hemangioma and a cavernous hemangioma, so go by two things, the clinical and the pathology picture. Clinically, please remember, whenever some superficial site is mentioned, like over here they said skin, eyelid or skin anywhere in the body, it is a capillary most likely. Whereas if there is a deep site mentioned, so for example some organ is mentioned, like they would have mentioned liver, then think of cavernous. In fact, which is the most common benign tumor of the liver? Can you tell me? The most common benign tumor of the liver is a cavernous hemangioma only. So simple. Capillaries are going to involve all the superficial sites and cavernous is going to involve all the deeper sites. Well, having said that, please remember one more thing, guys, that when you look at capillary in terms of pathology, microscopically, you will see very small capillary size, small blood vessels. Whereas when you look at cavernous under the microscope, you look at huge channels. There are huge channels that are noted. So have a look at it. See, when you saw capillary, they were small red colored cells and blood vessels, tiny. Whereas when you saw cavernous, cavern means dilated. Look at the size of these channels. It is huge. So yes, capillary chota, cavernous is going to be huge. That is how you differentiate between these two, and that is what you have as capillary hemangioma. Look at it. It was where? It was on the skin. It was on the skin. It was a superficial site. You had to think of capillary. You would not think of cavernous. What are the other options? Pyogenic granuloma. As far as I know, pyogenic granuloma is known as the pregnancy tumor. So some pregnancy history should have been given. Bacillary angiomatosis, firstly it's not commonly seen in children, but can you tell me in microbiology, bacillary angiomatosis is caused by which organism? It is caused by Bartonella henselae. So yes, that is another set of important information that you have to know. Going forward, let's move on to the next question, which was personally my favorite, and I hope such questions come more. Macrophages are inflammatory cells for chronic inflammation, as all of us know. In fact, for chronic inflammation, the most important cell of chronic inflammation, The most important cell of chronic inflammation is the macrophage. What are macrophages of the liver known as? I hope each one of you got this right, and that is Kupffer cells. So tell me quickly the answer to the others. For liver, it is Kupffer cells. Where do you see littoral cells? Littoral cells are macrophages of the spleen. Splenic macrophages are littoral cells. Who has all the dust? Carbon, dust, pollution, lungs. So the lung macrophages are known as the dust cells. And who has the glia and the glial cells? The brain. So remember, the brain macrophages are known as the microglia. These were the other options, but I hope you could answer. This was quite an easy one, that is Kupffer cells. Coming on to the next one. There's a 65-year-old chronic smoker who presented with intermittent claudication of the legs. Initially, the pain was at rest. Later on, so initially I think they must have given it as initially the pain was at movement or on moving, and later on it was at rest also. What is this also known as? So firstly, I gave you one mnemonic few days before an exam only. That was, whenever they will give you the history of BD, you will think of Burgers. Whenever they will give you the history of BD, you will think of Burgers, right? So I think the history of BD and cigarette smoking was given. So you had to classically think of Burgers. Some students said Burgers was not given in the question. The other name was given. So what is the other name of Burgers? It is TAO, thromboangiitis obliterans. The other name was thromboangiitis obliterans. So please remember TAO, because that will tell me there is a thrombus in the blood vessel. Blood clot, thrombus. There is itis, means inflammation in the blood vessel, and the blood vessel is obliterated. So imagine this is a blood vessel, it's totally closed, obliterated. That is the reason that my patient is having pain, intermittent claudication on movement and then on rest, and that is the reason that this gangrene toes have been shown, because blood supply is cut off. This basically means that eventually the patient will land up with gangrenous feet, gangrenous limbs. And that is the name, Burgers, TAO. Just a word of caution over here. When you have Burgers, and I always tell you to keep caution over here because this is where the examiner will catch you. The Burgers which is related to the vessel is BUE. That is, the U is the V. The one with U is going to be the one with V. Whereas when we talk about Burgers, BER, that is the other name for IgA nephropathy. That is the other name for IgA nephropathy. Basically, that is a kidney problem. The Burgers with the U is a Burgers with a V, that is vasculitis. Coming back, classically, we have the BD smoker, and the BD is going to be for Burgers. Having said that, moving on to the next question, which is a surgery path mixed. There's an adult male who suffered from road traffic accident. Grafting was done using own body tissue. Own body tissue. Which kind of graft is going to define this? So you've got 4 grafts. Tell me the definitions of all. When we have autograft, autograft means self, like this was done over here. So this is the answer, autograft. When eye for eye, when it is done between twins, like identical twins, then we are going to call it isograft. When it is done to do with all members of the same species, all of them are belonging to the same species, means the donor and the recipient, human to human, anything like a liver transplant or a bone marrow transplant, as long as it's same species, all of them are all the same species, so all are of the same species, that is allograft. And xeno means if we are dealing with some different species, means if some animal valve has been put in us. So it's basically like prosthetic heart valve. So an animal valve put, so that is something we call as xeno. So repeating, as long as we have auto means self. Eye for eye, iso is going to mean identical twins. Allo means all of them are of the same species. And xeno means different species. What is the answer over here? Own body grafting was used, so autograft. Having said that, let's move on to the next question. Characteristic feature of hemolytic anemia includes reticulocytopenia, decreased haptoglobin, neutropenia. Firstly, all of them cannot be there, that's obvious. Neutropenia and hemolytic anemia don't have much of a correlation. Tell me something, if hemolytic anemia is happening, means this is a red blood cell, this is a red blood cell, and someone is breaking your red blood cell. Either the spleen is breaking or genetics is breaking or antibodies are breaking, but the point is that your red blood cell is breaking. So what is your bone marrow going to do? If your red blood cell is breaking, basically there is hemolysis, your bone marrow is going to increase the production of the cell. Your bone marrow will have to work more, right? So how can your reticulocyte count go down? The reticulocytosis will occur, not reticulocytopenia. So that means, which is the feature seen in hemolytic anemia is this, decreased haptoglobin. What do I mean by that? See, what is happening? Your blood is breaking. The RBC is bursting open. RBC is breaking. This means all the hemoglobin is getting released out of it. If this was an RBC, now that RBC is all going to break, so that means the hemoglobin has been released out of it. How and whom will this hemoglobin bind to? Everyone needs a partner in the body. So hemoglobin goes and binds to haptoglobin. Who is the travel buddy for hemoglobin? Hemoglobin has kept a travel buddy called haptoglobin. So yes, it is going to go and bind to haptoglobin. As a result of which, do we see that initially haptoglobin was roaming around alone. Now it's got a lot of hemoglobin. They've become buddies. So will the free haptoglobin levels decrease? Yes. So that is what is characteristic of hemolytic anemia. Well, having said that, moving on to the next, what do we have over here? Look at this, a child went for ocular surgery and there's an eye tumor wherein enucleation is done. What is the gene implicated in the pathogenesis? Child with an eye tumor, and I am only and only thinking of one, and that is retinoblastoma as the tumor, and the gene is obviously very obvious over here. It is the retinoblastoma gene. I hope you remember the chromosome for it. Retinoblastoma gene is said to be what? It is said to be the governor of the genome, and it is chromosome 13q14. So there are a couple of things for which you should be knowing the chromosome here. I can see all the options here. P53, policeman. P53, which you call as the policeman, that is going to be present on which chromosome? Chromosome 17p13. From there only you continue. What is present on 13q14? Your governor is present on 13q14, and that governor is basically the RB gene. That is also there. What is the third option? RET. If you all remember, I always used to tell you RET 10 med men. Do you want to revise this one last time? What is RET 10 med men? RET means the name of the gene is RET. 10 means the chromosome is chromosome 10. Med, what is med, guys? Med is the tumor, medullary carcinoma thyroid. And what is going to be men? Men 2A, men 2B is the syndrome. So repeating, RET is the name of the gene, 10 is the number of the chromosome, medullary carcinoma thyroid occurs, and men 2A, men 2B are the syndromes with which it will occur. That is RET 10 med men. Coming to the last one, MIC. What is it about MIC that you should be knowing? There are how many types of MIC on which they will give you a question? They will say MIC is of 3 types, C, L, N, colon, that is the mnemonic we always studied. MIC is going to be C-MIC, L-MIC and N-MIC. And which are the tumors in which they are mutated? N for N. N-MIC is mutated in neuroblastoma. L-MIC is mutated in lung cancer. Which lung cancer? The lung cancer with lots of L's, that is small cell lung cancer. And what is C-MIC? C-MIC for some childhood lymphoma, guys. Which is the childhood lymphoma? Which is the Bachcha lymphoma? The childhood or the Bachcha lymphoma is the Burkitt's lymphoma. It's gonna occur in kids, right? So please remember these 3 MICs that we have. Quick revision. There is a C, L and N. C is going to be for childhood, so that is the Bachcha lymphoma Burkitt's. L for L, all the L, small cell lung cancer, and N for N, that is neuroblastoma. Coming back, I discussed all, but the question here was quite simple, that is retinoblastoma. Okay, moving on to another easy question. Which of the following is involved in sickle cell anemia? Now, I think before I go on to reading this, we know our answer. At the beta 6 position, what changes to what? There is something called glutamate, which will change to valine. So, glutamate is going to go and valine is going to be welcome. So, glutamate is going to go, valine is going to be welcome at beta 6 position. So the answer, if you know the answer, you will just have to search for it somewhere in the options. That is what you see in a case of sickle cell anemia. One more point, because it's happening just at one point, this happens to be a type of a point mutation. This is a point mutation. Coming on to the next question. Which of the following stain is used for the necrotic heart tissue staining? Or necrotic heart tissue basically means a case of myocardial infarction. So what is the famous stain that we use? TPTC. What is TPTC? All-time exam favorite in FMGE, yet proven once again. TPTC stands for triphenyl tetrazolium chloride. Triphenyl tetrazolium chloride. And even if you don't know the full form, if you know the number of alphabets, triphenyl tetrazolium chloride, that is 4 alphabets, means this is going to help you as a gross stain within 4 hours of myocardial infarction. Within 4 hours of chest pain or 4 hours of myocardial infarction, TPTC is going to help you. How is it going to help you? TPTC, 4 alphabets, 4 hours. Because if you add and you see that there is a brick red color, if you see a brick red color, this means the heart is totally normal. Whereas, if you see the presence of this, that is a pale area, this means the area has undergone a myocardial infarction. So remember, there's a brick red color, everything's good. If there's a pale area, then I'm worried, that is myocardial infarction. Okay, moving on to the next question. Here you have, which of the, actually a medicine question I feel, which of the following is a marker of intestinal inflammation? Nowadays, there are 2 very famous markers called fecal lactoferrin and even calprotectin. Calprotectin and fecal lactoferrin, these 2 are very good for testing intestinal inflammation. So in case you had this in the options, you had to pick up this. I hope everyone's been able to mark it. Coming on to the next one, there was a question which was more or less descriptive but quite a classical description. You had a 50-year-old female who's come to you with knee joint pain. Maybe the knee joint history was not that typical, but the pathology was quite typical. Microscopic examination shows needle-shaped crystals which are negatively birefringent. So guys, please note something. We always know difference between gout and pseudo-gout. So now gout always involves the small joint, small name, small joint, big name, pseudo-gout, big joint, small name. That is going to be a little younger population, somewhere in 40s and 50s. Pseudo-gout, big name, elder population. That is what we have learned. Gout, small name, pseudo-gout, big name. Gout, small joint, pseudo-gout, big joint. Small people, small in the sense still 40s, 50s, but pseudo-gout, big name, so elderly people. But now what happened was that they gave me a history of a 50-year-old, so I think it is somewhere for gout, and they've given me a big joint, knee joint. So I am now confused. I will have to rely on pathology. Pathology shows needle-shaped crystals which are negatively birefringent. That is what you see in the monosodium urate crystals which are to do with gout. So remember, monosodium urate crystals. Can you see the shape? Can everyone see the shape? Yes. What are they? They are needle shape and they are negatively birefringent. So as I always say in front of pathology, you have to go by what the pathologist says, right? It's feeling quite important. Having said that, so negatively birefringent and needle shape means we were dealing with monosodium urate crystals, means we were dealing with a case of gout. On the other hand, if we would have been dealing with this, look at this blue color rhomboid. These blue color rhomboid are positive refringents, these rectangle rhomboid kind of things. What are they? They are the ones which you see in pseudo-gout. These are CPPD, calcium pyrophosphate dihydrate crystals. So over here, because needle-shaped crystals are seen which are negatively birefringent, I would have marked gout. Okay, having said that, I think this happens to be the last question. Yes, of course. And any other questions which you feel that I might have missed out or I'm rather still searching for and trying to recall, please do write to me. You can put it in the comments below. Anything that you know has not been covered in this recall, I can always help you out in the comments by answering it. So thank you guys so much for joining in. Just an update. I think I am personally very excited to tell you that after after a lot of requests from the students for asking for recorded lectures, Unacademy has come up with NEET PG Vitals. NEET PG Vitals is basically something which is the same Unacademy platform, but now there are videos, and these are not recorded lectures, previous lectures. A proper recording has been done for all of you for all the 19 subjects, and that is by the name of NEET PG Vitals, for which you can definitely take a special separate subscription, and all the PDFs of those lectures. So these are not live classes, these are recorded, which you can hear on the go whenever you have time, and these are being done for all the 19 subjects. I have taken pathology and microbiology both under NEET PG Vitals. Microbiology is completed, it has already been uploaded. Pathology will also be uploaded in the next 15 to 17 days. Yes, so having said that, I hope everyone's okay with it. Also, there's another, if you want to join in for live classes, there is an offer that is going on which has been extended till Jan 28th and even beyond, and that is a 20% off on all the medical subscriptions. You can use the code PATHO10 for either of them if you want to join live, then this batch, and if you join for one batch, it gives you access to all the batches on the platform, live and recorded. But for NEET PG Vitals, it's a separate subscription that you can go in for the 19 subjects. Thank you so much guys for joining in. I hope I've managed to give you a good insight into what the exam pattern was. Definitely we are on the changing side, but yes, I don't think any of this topic was unheard of or unexpected. For pathology, at least I can say we were on track. Our preparation was good enough. We could manage most of the questions. Yes, going forward for a lot of subjects, things are becoming tougher. So my advice to the future students, the NEET PG and the FMG students is focus on your integration and do not leave any subject. It's not about, I always say, you don't have to do a PhD in any one subject. You have to be jack of all trades. You have to know 80% of all the subjects and you will sail through. If you know 100% of one subject and you don't know the other altogether, that's not going to solve your purpose. You have to know 80% of all the subjects, all the 19 subjects you have to touch upon, and that will get you a good score and a good rank. Thank you for joining in. As always, a great, I hope you've had a great session. I personally did. And yes, looking forward to the comments. If I've missed out on any question, do type out and I'll help you out. Thank you so much.